Our next speaker is Dr. Michael Osborne. Dr. Osborne is a pain specialist at the Mayo Clinic. He is the director of the Pain Medicine Fellowship Program, and he is going to talk to us about the pearls of opioid management. Dr. Osborne.
Thank you, Andy. So just to introduce myself, I'm a physical medicine specialist by trade, and I work in the pain department at Mayo Clinic. And I think Dr. Sletton's talk was a really good preamble to what we're going to talk about now about opioid use, because you'll find that one of the key drivers in decision making regarding whether to use opioids or not is understanding the pathophysiology. And paramount to that is trying to figure out, are you dealing with a nociceptive pathophysiology or a centralized pain type of pathophysiology, because the two respond very different. I have no disclosures. Here are the learning objectives. So Dr. Sletton stole one of my slides, obviously, but I always start out talk on pain with this definition, because I think it really shows the dichotomy and variance in really the pain experience. The words in red are harbingers of the somatic nociceptive part of the definition, and the words in pink are more of the emotional and affective parts of the definition, and both are very real components of the pain experience. I kind of talk to my patients about the tissue-based pain, nociception. I talk to my patients about the centralized component of their pain and the suffering, and trying to tease out how much of each of these is involved in your patient's pain experience can be difficult, but I think is very important when you're trying to decide on treatment strategies. So just to take a step back before we jump into prescribing opioids, is to remember what you do every day and take a broad approach and a multidisciplinary approach, and I'm sure everybody does. But sometimes it's easier to pick up the prescription. Well, we don't pick up prescription pads anymore, right? We put them in our computer and send them off. But it's easier to use medications, physical therapy, procedures, and surgery than it is maybe to do patient education or psychological interventions. But I think without patient education, really you might set yourself and your patient up for some limited outcomes if you're not both on the same page as what your goals are with the treatment. So I would say, whatever you decide to do, having a sit-down talk with your patient on the goals and objectives, the disease, the natural history, prognosis are all very important. And that's very difficult. You have very limited time with